seem to have paused on there. Can we hear each other?
Yeah.
Okay.
Yeah, I can hear you, Josh.
They're frozen.
We're just having our own meeting.
Sandra did bring that up before.
Yeah, oh, way ahead of you, mate, way ahead of you.
Most people are, Sandra, to be fair.
Oh, go on with your whatever.
Oh, come on, Kevin. Come on now, mate.
Most beautiful day we've had all spring, and we're all sitting inside watching our computers.
That's right.
What would we all say to our kids right now if we could see if they saw us doing this?
Yeah. Yeah. Get off the screen as an oft-used conversation in our house. So I'm not really living that value right now.
Yeah, absolutely.
And yeah, well, you might just have to take us through everything.
We've got the Zoom back.
Got the Zoom back.
Zoom back.
We're back.
Yeah, you're back.
Have we got the live feedback?
But I'll just ring Jamesa.
Looks like it.
Nothing happens.
Live on custom live streaming service.
3 times now. Yeah, thanks.
Hey, are we live still? Are we? Yeah, we're good to go. Okay, cool.
Okay.
Yeah.
All right. Sorry about that.
I'll go back in. It's all right. Here we
Sorry
are.
about that, everybody. We technical difficulty, but we will proceed. Josh, can you open our meeting, please, FY?
Sure can, e hoa. Ai te whānau me noi tātou. E o ngā mano, a tēnei te whakamoi matatu ki a koe mō tēnei hui ngā amatu. Arahina mai ki au ki te tika ki te puni a mātou. Na tukuna mai tō wairua tapu hei manaki, hei āwhi, hei tiaki hoki a mātou i ngā rawa kore, i ngā tini, i ngā pani. Ngā whānau i raro i tā rātou pauritanga, tā rātou māwiwitanga. Anei mātou e pā e tuohu nei mui tuaruaru, a ka tuku i tēnei inui i rungi i tuingo o tō mātou kai whakora i Ukraiti. Āmini.
Kia ora, Josh, thank you. And morning, everybody. So we've got a reasonably light agenda this morning, but a number of discussion matters for a bit later on this afternoon. So I still anticipate we'll be running the full course of the meeting. So to start with, we have apologies for lateness from Tony and Hickey. They'll both be joining us shortly. Item 2.1, does anyone have any additions or deletions from the schedule of interests?
Madam Chair, I have an apology from Na. He's unable to make it onto Zoom today.
Kapai, thank you.
You're welcome.
Any conflicts in relation to today's items? Then we go to the minutes from our meeting on 28th of September, which are at page 7. Does anyone have any amendments to the minutes? Okay, thank you. Then we will note and adopt those minutes. Any matters arising? And the action items at page 12, if we can pass to you, please, Jim.
Yes. Madam Chair, first of all, I have to find. My goodness. Okay. So, page 12. Yep. So the ED alcohol presentations, I did do the pros and cons, as you will see there. I just think there's so much going on at present. It's not that highly important. If we could just drop that one, I'd appreciate it. Code of conduct is drafted, and we're just going through it over one last time. Should have it up for you for next month. And the virtual diabetes register, we never got around to checking those.
Good to know what the question was again, sorry.
It was when you looked at that table that I think Ian put in last month, there were some figures that didn't seem to work.
Yeah, they don't.
properly.
Never have had with virtual.
Oh,
So they're an
because they're-
estimation based on population, not based on actual.
Oh, okay. So is that on our census population or health service users?
Census population.
Yes, which therein lies a problem.
Yeah.
Probably
Yeah,
would be better for
there was always an
census.
issue.
Okay. Does anyone have any questions on the action items?
No.
Okay. And we move to correspondence, which you will see in the papers. Very pleasing to have the letter from the Ministers of Health and Finance approving our annual plan for the current year. And then we have the performance dashboard at page 14. If
Yeah.
there's anything you'd like to highlight, John?
Yes. So note the reduction again in immunisation in 8 months, and that will be directly as related to people not coming out of their homes when we went into lockdown in up to level 4 for a period of time there. It has that instant effect on people not coming out. But we are seeing, prior to that, we were seeing some really good results out of the work that was going on between Te Rangi Health and the immunisation outreach team to get people, children vaccinated in relationship to that, and they haven't stopped. As soon as they could get back into it again, they got going again. So we should see those rates improve again as a result of that. Liz, I noticed you were 100% for better help for women for women there. You know, she's
Yeah, brilliant.
yeah, brilliant.
From a hospital perspective.
Primary care, that result's just not going to improve because they're just not seeing people to be able to give them advice because they're seeing people virtually very often. So they're not seeing and doing that as part of that. It won't come right for a long period of time. I think the other one that I just wanted to highlight in there is the effect, and you'll see that later on in my report, just a few less people coming through the emergency department with the lockdown period having the effect and the follow on from that. Great result again around diagnostic waiting times, clean sweep of all being within target there. And again, if I remember correctly in here, we had 100% of people on track for faster cancer treatment, which again was a really good effort to try and make sure that people weren't disadvantaged as a result of the disruptions that we've seen with care over the last 6 weeks or so. That's about it.
So I'll pass up to the Zoom screen first if anyone's got any questions on the performance dashboard.
Yeah, Kim, I just had one question, and it was really just a clarification. In patient safety, top of page 15, what constitutes a medication incident?
Fundamentally, whatever people report as a medication incident. So it may be as simple as a dose that was given late and somebody reports that, through to somebody being given a medication in error, so the wrong person or the wrong dose or those sorts of things. So there's quite a range within those that are reported.
Okay. Thank
So
you.
no matter what it is, they are followed up usually, well, in conjunction with the pharmacists to review what happened, and you know, if it's something more significant at the time, then that will be reviewed with the patient at that time and the clinicians. But generally, they are reported incidents where they are less significant.
I also have a question, Madam Chair. It was generally just in regards to the reporting of our stats. For instance, if I take hospital events, which will probably be the one most effective, in light of possible COVID flooding through our community, I'm assuming that these statistics are going to just skyrocket, right? And so if I look at bed utilization, our target is usually over 80%. And the assumption is that if COVID does come to Te Tairāwhiti, the bed utilization will probably rocket like to 100%. I'm assuming. Is that a correct assumption to make there, Jim?
Well, it's not necessarily, Josh, because bed utilisation takes into account planned care as well. So if there was a large influx of people who were COVID positive, we would be trying to maintain some planned care, because there would be people who just cannot wait. But some of the less urgent planned care would be postponed, especially for people who are vulnerable, and we don't want to bring them into an environment where they may be exposed to the virus. So, yeah. So yes, there would be some trade-offs. And what we saw last year when we were in lockdown and there were cases within the community was there was lesser loading in the hospital over that period of time. But you're quite right. The modelling shows that we would, depending on where the modelling sits, that there would be more people coming through and being admitted to hospital. But those are not huge numbers, and we'll look at those a bit later on.
You make an important point, though, Josh, about the impact on the hospital of COVID cases coming in and limiting our ability to care for people.
Yeah, and I guess it was the general impetus to my questioning was around if that's going to be a thing, and we as a board are responsible for looking at the data and how, or monitoring what's going on by being informed by the data, then how would our current data take into account that surgence? But yeah, I hear your point too, Jim. We can have that coordinated with the further information later on.
Yeah,
thank you very much.
I think without being too alarmist about it, two things. One is that the progress that we've been able to make around planned care, that's reported in my report as well, would be and has already in some respects been halted and has gone backwards a bit as a result of just having the change in alert levels, let alone anybody in hospital with COVID or in our community with COVID-19 or in hospital. So that's changed. And the other point around the government's change to the red, amber, green system as opposed to the old alert levels is around preserving capacity within the health system when the virus is spread throughout the country, which we know is only a matter of days or weeks away. And so that a large part of that is to try and maintain the capacity within the health system, as you pointed out. And it's not only about being able to respond and treat people who are COVID positive, but also still to be able to respond to the person who has a heart attack and needs to be cared for as well.
Cool, thank you, Jim.
Any other questions from the Zoom on the performance dashboard? Carl, from around the table? No. Okay, thank you. We'll receive that, and I'll just briefly move to my report for the month. So not unsurprisingly, the month has been very pointed at our vaccination program, pretty much exclusively, to be honest. I really do want to acknowledge the very significant efforts of our teams from not just Hauora Tairāwhiti, but also Tūranga Health and Ngāti Porou Hauora, not just for the day-to-day efforts that they're making to increase the vaccinations in our communities, but the really big response that they pulled out for Super Saturday and also for the Prime Minister's visit, which were, two big additional things on top of the vaccination program. But despite those sustained efforts, we are currently the lowest in the country for first dose, sitting at 76%. And along with two other DHBs, lowest in the country for second dose at 61%. So it is a deeply concerning situation that we're in at the moment. For Māori, our rates are even lower. So we're at 65% for first dose. And that's the same percentage as one other DHB and higher than 5 others. And for Māori second dose, along with 2 other DHBs, we're currently at 47%, which is higher than 6 other DHBs. And I make that particular point because you would have seen media coverage over the course of the last week or so, criticising particularly our Māori vaccination rates, and they're lower. I'm deeply concerned about them. They are lower than our whole of population rates, but they are not the lowest in the country, and they have not been the lowest in the country. But what my concern is if we can't lift our performance, they will become the lowest in the country. The only thing this really reflects, though, is that all DHBs are performing poorly for our Māori populations. And as Jim said, COVID spreading around the country is imminent, and it's our Māori populations who will suffer under those conditions. So just also reflecting on the announcement by the Prime Minister of the traffic light system, which includes a government check-in on the 29th of November on how all DHBs are progressing towards the 90% target. So in order for us to get to 90%, we need to vaccinate a little under 5,900 people, 5,000 of whom should be Māori, for their first dose. And then along with all of those people coming back for their second dose, we also need to vaccinate a further 6,500 for their second dose. So we've got a long way to go to get to 90%. I'm personally very, would like to have a discussion a bit later about our pathway towards getting to 90%. Our timeframes that we think are ideal, and which will not be the same as what is likely, but I think we need to have a proper board discussion about that. But what my big concern at the moment is that if we don't get to 90% by the end of November, there will be real consequences for our community. So, you know, once regional movement opens up, the virus will find its way here, and under 90%, we are seriously at risk here. It's not clear yet what decisions the government will take when it does its check-in. But if Auckland has reached its required vaccination levels, the choices would seem to be to allow Aucklanders to move, which would risk our population health, or to keep Auckland's borders in place with a really significant economic impact on Auckland and indeed the rest of the country, and an ongoing social impact on Aucklanders, or to let Aucklanders move and put borders around low vaccinated areas. And if that occurred here, that would have a significant impact on our regional economy. And to me, none of those scenarios are acceptable. Like we have to do everything we can to not have one of those scenarios. And I'm also deeply concerned about the potential for divisiveness in our community. We are seeing that starting to play out, and you know, we have for a long time been saying this pandemic would become a pandemic of the unvaccinated, and that's certainly what it will become when the passports are introduced and the vaccinated can do things that the unvaccinated are not able to do. So it's just on so many levels, it's so important that we put everything into getting our vaccination rates up. The discussion that I'm keen to have a bit later is on what we're going to be doing over the next 5 weeks and what we realistically think we can achieve and the consequences of not doing that. That was a little bit of a coho, but that's kind of how I'm feeling at the moment. And I do just want to again underline that just the great appreciation and acknowledgement of our teams who are working every day to try and get our communities vaccinated. So happy to take any questions.
Madam Chair, I do have one question, just a question of clarity.
Yeah.
You had said we have to vaccinate 5,900 people, is that right?
Yeah.
First dose?
Yeah.
And 5,000 of those need to be Māori?
That's
is
right.
that the number?
Yeah.
5,000 of those, 5,900 needs to be Māori for the first dose. Just wanted to make sure that was clear.
That only gets us to 90%. There are still 10% out there, which is
4,200.
for our community, 4,200 all up, 1,900 of whom are Māori, who are not counted in the 90%. They would be the missing 10%.
I really want to support your kōrero and the general message that you're sending about that this is really important. I know that one of the things that in the dialogue that's always spoken about is about regional economy for Auckland, regional economy for Te Tairāwhiti, but there's also this social and community and mental health economy and environment that is affected when borders are maintained and stuff. You know, there are people that have whānau members. We recently just had whānau pass away here in Te Tairāwhiti, and people that are over the other side of those borders, unless they were directly part of those whānau, mum, dad, that kind of thing, they weren't able to come to those tangi, So I appreciate when I hear our Deputy Prime Minister talk about the impact to our country's economy, and I agree with him. But I think one of the things that is not really spoken about a lot is the fact that whānau can't go to tangi without if these borders are still maintained. And for me, and I completely agree with your words, Madam Chair, that for me the tool for us to be able to gather together in our traditional ways, and I'm talking in terms of te ao Māori, our traditional te ao Māori ways, is to become vaccinated. So I just really wanted to speak to that part and add that part to your kōrero there, Madam Chair. Thank you.
And you're right, the social cost is, it's just unknown at this stage. The impact on people, the long-term mental health impact, the impact of disconnection. It's, I think those costs will be coming home to roost for quite some period of time yet.
Do the under 12 sit outside those numbers?
Yes, they do. Yep, that's
Yes, I don't think we can underestimate the importance of protecting our under 12s until they're able to be vaccinated next year. And then, of course, there'll be our under 5s who, at this point, won't be getting vaccinated. They're our most vulnerable in the community.
One other thing that I did want to mention too was to remind us of the fact that a large chunk of our Māori population have only been eligible to get vaccinated since September. I think it was August, sorry. So there's a huge chunk that were in the later phase of people coming through. So there's a lot of people out there that sit in that are keen to do it but need to connect in space. So just to add that for context, not really talking to us who know the information around the table, it's really talking to whoever might be coming into this live stream, really. So I just wanted to add that last note. Thank you, Madam Chair.
Thank you. I mean, that's technically correct in terms of the tier system that the government operated for the groups coming through for vaccination. But that said, we have always been a lot more flexible, and if people presented for vaccination, we've vaccinated them and just done it.
Yeah, but we haven't, we've done that on the basis of if they presented.
Yeah.
We haven't gone out there to encourage them to present. And if there was going to be a DHB that was going to be last in the country, it was always going to be us. We've always wanted that never to be the case. And we've tried very hard not to be the case, but it's come to pass.
It has come to
It is
pass.
the case because of our population dynamic.
Madam Chair, Robin and Sandra want to have a cordial on here, so up to you who goes next.
Thank you. I can't see hands up or anything, so do just sing out. Robin.
I just had a question I put in the chat. Have we been able to locate by mesh block where the 5,900 are in our rohe?
Yes.
I'm taking a pic. It's in what percentages in Kaiti?
Yes, we know exactly by mesh block, and we produce heat maps at a street level that tell us exactly how many unvaccinated people are within a block. So yes, we have that information. We provide it to Toitu Tairāwhiti and our iwi health providers to help sharpen their more granular vaccination efforts. So when they're going into vaccination in the park and street by street, they know exactly where the most at-risk blocks are.
So are we able to know as board members what the percentage is in Kaiti?
Yes, I'll get that to you a bit later. I'll just have to pull up figures, but Alta Kaiti is a hotspot, as is Ruatoria, Elgin and Te Hapara.
But you shared that with the board last week.
Yeah, I
No,
did.
that was just committee level though.
Oh,
Right.
okay. Okay, so I gave a presentation at Hui Tirangi, and I'm happy to run through that again this afternoon.
Yeah. Thank you.
Sandra, want to say?
Sandra?
Thanks, Kim. So my concern, along with those already expressed, is that we are seeing a move from central government around mandating industries, whereby we've mandated across healthcare, we've mandated across education. My concern is for our people when they start saying hospitality, primary industry, etc., because suddenly then we've got people who actually don't have jobs, never mind protection as well. They are in line to lose their employment, or at least have their employment severely curtailed. It's something that I wanted to mention, and I think perhaps later on today we might be able to discuss a wee bit more in depth, but I think it's important to flag that, that we will have people in our communities who won't be able to go to work.
Well, they will be able to if they choose to vaccinate.
Exactly.
They won't be able to.
That's my point.
Choose not to.
Yeah, absolutely. Yeah, that's right.
Yeah, so they won't be able to go to work and spread the virus on to other people.
Tony.
How are we measuring the success or otherwise of the iwi health providers who are targeting mesh blocks? How are we?
So we have site by site, day by day vaccination numbers that come through. We know exactly how many vaccinations have occurred by each provider. We know that collectively iwi providers have delivered more vaccinations than the DHB. They are a critical part of our vaccination effort, and we just couldn't do things that they are doing. So I just can't emphasise how important they are to us.
Yeah, that wasn't probably the point of my question. I mean, we know that there's a demographic, particularly with young Māori, 20 to 35, that's really difficult. I've had so many conversations with young Māori guys in that demographic who just not interested in getting, there's a whole lot of other stuff going on in their heads. And in big workplaces, some places where half the staff were not vaccinated, I'm thinking, gosh, you're going to struggle to run your business when this hits. So, we don't have the privilege of waiting to see whether any other providers other than us hit the mark. And I'm making sure we get really monitoring to see whether those numbers are increasing, not simply on a mesh block or a heat map, but actually on a demographic, because if we're not making inroads in that group by doing this, then we need to change it up.
We monitor by ethnicity, by age group. by site. Tūrangi Health goes into workplaces, so they have been into Ovation, Pultron, Leader Brand.
Do we have, like, I know we've got our general targets, but do we have like time targets? Like,
So we can talk about that this afternoon when I was just talking about pathway to 90%. Yeah.
thank you.
Chair, I can talk about it this afternoon too, but where the trust with its sort of EDA hat on, Tony, it's working directly with the iwi health providers on getting into workplaces and communicating through their methods. So we can talk about the actions we're taking this afternoon.
I'm just a little bit worried about about potential burnout for iwi providers, and we see overspend for our you know what's going on with COVID numbers that we've just had, and it's in Jim's report, but the same goes with iwi providers. You know,
so iwi providers, resourcing is not an issue. So the government's been very clear with us about that. We have put resourcing directly into iwi providers. They get paid per dose of vaccination delivered, and there is now the $120 million fund that's been opened up. And we've been very clear all the way through that if there are things you need, let us know and we'll make sure the resourcing will flow. Also, Ministers Allen and Whaitiri have been working very closely with us to make sure that resourcing flows from Wellington directly into our iwi providers. In terms of burnout, I absolutely agree. They have been working, all of our teams actually have been, you know, working clinics day in, day out for months. And we want to do everything we can to try and reduce how much longer they're going to be having to do that.
Could I just add too that it's a joint effort. It's never been just about what Māori providers, our Māori health providers are doing. It's they lean in frequently to DHB. The numbers that we're seeing are our shared numbers. And while we can recognise there are different achievements in different parts of the system, we know that the effort that Māori health providers has put in is way above and beyond what we should expect in any one working day, and they have been doing it for months.
Okay, so there's some conversation lines in there that we'll pick up a bit later in the day. We move to Te Hauora o Nukutai Memeha. Josh, in Na's absence, is there anything you wanted to feed back to the board?
One moment, Madam Chair, I actually have food in my mouth.
Okay, I'll go to Jim first and then come back to you. Jim, if we can go to your report at page 16. And just before we do, I did just want to say that it's good news on the admissions and on the FSA numbers.
It is. It is. So just highlights from my report. So the financials weren't a highlight for the month, but this was raised at the FRAC meeting last week, and we didn't get into some of the reasons around that until 3/4 of the way through the kōrero. So Gavin, I put that second paragraph there in this report just to highlight that we did make that decision to shift quite a bit of our resourcing out of the first 3 months of the year and put it in the second half of the year. Over $1.8 million worth has gone into the second half of the year. So when you take that into account, the first 3 months don't look as bad as they do in this. And the other thing too is that while we have got some revenue in there for COVID-19 expenditure, there is around nearly $500,000 of expenditure in there that is not directly covered by revenue that should be covered by that. And we have had the conversation about what else is happening within the organisation that is affecting our ability to get both revenue in and is driving our costs. And another example would be our ACC revenue is down at present because we're just not able to complete the same amount of that work with our current capacity and the lockdown changes. So it is looking, not looking, it is that we are about $1.8 million behind budget at this point, but we have got some confidence around how that, what's contributed to that and how that will or should change in the next few months, in that next quarter when we're back to our normal budgeting, and then when that other budget flows back in again in the second half of the year. So from a throughput point of view, last month was down. We had the flow-on effects of that period of time of lockdown that occurred within the month before, flowing into last month as well. And it did start to impact on our planned care, which I'll come to in a minute, but I don't want to go past the bottom of page 18. We're just looking at that graph around our paediatric admissions, where we had that real spike last month, the month before last, with the numbers of children in August in hospital with respiratory syncytial virus, RSV. And fortunately for us and for our whānau in Tairāwhiti, that was a brief but intense period of time there, managing that demand for children. But generally, our medical and acute admissions were down over that period of time. And there was a reduction in the numbers of people coming through the emergency department over that period of time, and that same sustained reduction in the numbers of people coming through the emergency department then going on to require admission, in part around the way in which we reconfigured our emergency department with a much higher proportion of emergency medicine specialists, and in part also the way we've reconfigured the rest of our services through developments such as the medical registrars, helping to be able to get definitive plans of care for people that do not necessarily require them to be admitted to hospital. I think I've talked a bit about the funder as well. The main issues there being the additional expenditure around those COVID-19 relationship costs. Key indicators, the faster cancer treatment I've mentioned before, and the immunisations being down. There's some stats in there that Liz provided me around a spike in the numbers of births in Tairāwhiti in the previous 12 months. Liz assures me that dates and times don't coincide with necessarily with lockdown, but something is happening in Tairāwhiti in the last 12 months plus 9, and up to 9 in the last period of time, because that was quite a significant bounce back in the numbers of births within our district, as the graphs show there. Planned care, so we're a little bit behind targets, as not surprising in the first quarter with the numbers of people coming through being held back in that period of time when we were not doing as much planned care over that period of time. But our trajectory compliance has been reasonably good on page 24, and we've been informed by the Ministry of Health that they will still be paying us our planned care funding for that first quarter because of those unforeseen problems that we have got. And we have, as was highlighted by you, Kim, still continued to reduce the numbers of people, or come back again on the numbers of people waiting for a first specialist assessment. But we've gone backwards a little bit on people waiting for treatment. So it's popped back up to 70 people waiting longer than 4 months for treatment, as opposed to 27 in the month before, and our high hopes that we would have cleared that out to 0 by the end of that time. I would highlight that graph on the bottom of page 28, where we've got that ever-increasing, well, it's gone down the last couple of months, but that increasing numbers of people with certainty within the system. So these are people who've had a first specialist assessment and have been given certainty about getting treatment. And then, but at the same time, we have that, I think it's a red line underneath that heading towards 0, and now that's flicked up again, but we're back on track to try and get that down. We're in that situation where we're making that steady transition from outsourced people and medicine doctors to in-source. We, in the month, had, I think it was 2 extra anaesthetists, a couple of people, new people in the emergency department, and our own ophthalmologist started, and our ENT surgeon also started, and you will see that in terms of treatment, ENT is one of those areas where we need to keep on making progress. We've still got 20 people waiting longer than 4 months there, so we will have some more capacity to be able to do that on site again. Emergency department, I've talked about flight team at a interesting month, as you will see from the reporting there. Just in those last sections around there, I think that just important to note that while we have our own fit testing training program within the DHB, we're also offering that service to our colleagues within aged residential care so they can train up their own fit testers to make sure that their staff are appropriately tested around their masks, their N95 masks. And just at the end there, a few discussion topics from me. Clinical leadership is the proposal that Anil has out around medical clinical leadership, for which the feedback is in and some final decisions need to be taken around that now. I've talked about planned care, vaccination, Kim, you've talked about, and we're going to have more conversations about that. Tracing, we have a commitment nationally to trace 3 people a week, is it?
No, 3 per day.
3 per day.
Exponentially increasing.
And increasing up, as you can imagine, with the numbers of cases jumping up in Auckland now and in Northland and in Waikato. There is more and more people that need to be traced. So our teams are working with that, and we are looking to recruit more people into tracing. And one of the benefits that we've got around our collegial work through Rotoku Tairāwhiti, we've got additional help for that, to be able to do that and train up some more people outside of health to assist with tracing and swabbing. Swabbing numbers are down at the moment, but we know only too well that when the first case arrives in Tairāwhiti, our swabbing rates will go up very substantially overnight. And so we have to have the capacity to have people, same with vaccinating, swabbing, will need to have that capacity able to do that. Isolation and quarantine facilities, we need to look at 2 aspects there. One is the way in which we're able to support people at home to isolate and quarantine when they become COVID positive. We know that once one person in the family is COVID positive, it's inevitable that the rest of the family people living in that household will also become COVID positive. So there are requirements around how we would manage that within the community, both from a clinical point of view and a welfare point of view, which we're talking about with primary care and with our iwi partners, iwi health partners, and more widely with MSD, etc., around the welfare aspects of that. And it may be sometimes that people are unable to isolate in their own home situation, because home is a very loose word, and it may not necessarily be possible for them to be able to isolate in whatever that word is that they use as a concept of that. So we need to provide spaces for that to occur as well. COVID in the community, we've talked about the mental health and addictions facility. The model of care for that was presented last week, the week before last week. Were you there, Tony?
No, it was presented in the afternoon. We had a hui in the morning.
Oh, yeah. Okay. And it was very well received, I believe, and certainly signed off to a point that that's now being utilised by the architects as to enable them to develop the final concept design, which will enable the ability to do the drawings and get out to tender. Child and Youth Hub, we haven't had it officially yet, but we believe that the ministry are definitely going to support the release of the money for that. Recruitment, we are still finding difficulty in being able to recruit enough staff, and while we have the resources and the money around COVID and vaccination, the actual people on the ground is an issue that is around clinical staff and non-clinical staff as well. So we've got our usual efforts around that to be able to try and improve that situation. We're fortunate that we've been able to recruit some more nurses for our intensive care unit, which is good, and and try and have the requisite numbers of staff and have more people being trained up within intensive care nursing to be able to mount a response when we start to get cases in the community that may require ventilation. Industrial relations, it was great in the month to have finally been able to reach agreement with NZNO's members around approval of the NECA for nurses, and prior to that, our midwives had agreed to the terms and conditions there, and also at the same time, or around about the same time, nurses covered by the PSA had also agreed, so all on the same or similar terms and conditions in those settlements. So now we have a major task for our payroll and people and development team to implement 3 MECAs, which cover probably at least 50% of our staff in a short space of time, and try and get that money out to our staff members before Christmas. But good to get them all settled. And also just in that area, we are, as in DHBs, are in negotiations for the final settlement phase of the pay equity claim for nurses. Also admin clerical, and have started negotiations with midwives around their claim. Oxygen and environmental, we've finally been able to get a contractor to be able to do the work on the hospital that needs to be done around ventilation systems and some building modifications that we agreed with the Ministry of Health to be done, and that work is started. We've got the contractor who is going to do the actual ventilation changes, starting work as well in relationship to that.
Jim, will that mahi have any impact on our responsiveness to COVID?
Yes, it will. So we are racing to be able to get that done at the same time as racing to get the hospital prepared. But if you may remember that we left a ward spare open so that we could actually decamp to that ward while we did work in other areas. So yeah, it's going to be.
And what's the sort of estimated time for completion on the oxygen work?
The oxygen will get done relatively quickly. It's more the actual other work around the ventilation systems that will take longer. We're prioritising areas like the emergency department and ICU first, and then gradually working through from there after that before Christmas. Yep.
But importantly, we have suppliers now.
Yes, yeah.
What did you say? Sorry, Kim. Importantly, we had. What?
Importantly, we've got people to do the work now, which was a wee challenge initially.
Cool,
yes, well, I think, just like Hauora Tairāwhiti struggles for people and, to be able to do things, so does our building industry in Tairāwhiti at the moment with so much going on. And just on site reconfiguration, more than 2 weeks ago now, we started to get, we put on readiness state all of our site reconfigurations ready for receiving the first people to be COVID positive here. So we've been ready for that. We have realised as part of that our reliance around for the emergency department around a tent to be able to triage and manage people in just isn't going to work. So we just bought a building to be relocated on site. We'll be here in about 10 days' time, and that will be placed outside the emergency department. So we're able to have another area, increase the capacity there. It'll help with our flows. We'll have a green stream, an orange stream, and a red stream in relationship to the start of the hospital. And those of you who've been through the hospital lately will discover nice red lines on the walls as we identify for people the corridors and the ways and the wayfinding that they will need to, mainly our clinical staff, but the members of the public who happen to come here in the future when we've got COVID positive people in the hospital and we're managing their care and moving them around the hospital as will be required for their care from the emergency department through to the wards and the intensive care unit where they will be cared for, and keeping everybody safe in that circumstance in the next few weeks' time, or tomorrow, or today.
Yeah. Does anyone have any questions of Jim on his report?
Madam Chair, I had a question on at the bottom of page 27. It relates to the dental numbers. At the end of 30 September, there were 14. What are the issues regarding that? Is it mostly adults? Is it rangatahi, or are these the ones that come into ED and then end up in the ward, or what's the situation there?
That will mainly be young people, children, and mainly children. And the number there will be in relationship to visiting ability to get visiting specialist people in to actually do the work, and that's been a little bit concerning with all the changes in Auckland and getting people to come in to do that. You see, we got down to 0 back in June, and it's ticked up a bit since that time, principally around August when we started to get difficulty getting people out of Auckland.
Thank you.
I had a question, Madam Chair. Thank you very much for your report there, Jim. I appreciate your kōrero. Also, one of the questions that I was going to ask was the stuff that Tony asked about ventilation systems. So it's great. One thing that whānau will often bring up with me out in the community is, like how they'll talk to me about how prepared we are, or ask me about how prepared we are and things like that. Do we have beds? Do we have the things? All of that kind of stuff. And my summation to them is really we have the ability to be able to put in the infrastructure. We have the things, but what we lack are the people in order to be able to the qualified and appropriately skilled people in order to be able to meet the influx. I was wondering if you mentioned it in your report. Now, I was wondering if you could talk more to the point about lack of our staff that to be able to meet the influx that will come from COVID. What specifically there are there? Again, to remind us as a board for talking points to be able to have these conversations with people out in the community, but also if there's anyone watching it, I think it'll be helpful for them as well.
So, I mean, a lot of that depends around how many people we will wind up having to manage within a hospital setting, both in general ward setting or in the intensive care unit. So, everybody knows we've got a limited number of ventilators in Tairāwhiti, and also that to be able to manage people effectively on a ventilator, you need the right, appropriately qualified staff to be able to do that. And we don't have unlimited numbers of those people. We never have unlimited numbers of those people, and currently we don't have unlimited numbers of those people. So we have got a number of people that already work within just in that particular area with our intensive care unit. We've got a number of people who used to work in our intensive care unit who don't work there anymore, but who are available to come back and work there and help run a roster to be able to man the ventilators that will be caring for those, ventilating those people who get to that extreme end of care required when they are COVID positive. And so, and then we've got some escalation plans about how we would try and to go to even greater lengths to be able to manage should the numbers of people be higher than what the initial modelling is, which is around about the 6 or so people needing ventilation at the higher extreme of numbers. And the other thing that we know around COVID-19 is that when people do need ventilation, they need ventilation for long periods of time. So it's not a case of just a couple of days and you're off the ventilator again. Some people are on ventilators for a number of weeks. And as you add more people into that, then you get more and more people requiring the capacity, and therefore you need more people able to actually work the shifts required to care for those people. And that's generally done on a one-to-one basis. So that's sort of about the reality of our health system capacity here in Tairāwhiti, and the reality of the government's traffic light system to be able to manage that. So we get regular requests from Auckland, for instance, for more people to help out there because they have got already that capacity issue in Auckland. And the size of the health system in Auckland, and our size of the health system here is going to be severely tested should we get to that point.
So in terms of like just to draw on the appropriately qualified staff to operate the ventilator part, are the ventilators a highly technical piece of equipment that require intensive monitoring by bodies or by appropriately trained staff? Is that generally the crux of the machinery?
Yeah, well, I mean, Anil would be a good person to answer that question. He's there.
Yep.
Yeah.
Hi, Josh. Yeah, look, so the two issues. One is the technical aspects of the machine and the things that are required for managing the patient, and the skill set of the clinician. So normally you would expect that a complex COVID patient would require an intensivist on site or at least available through telehealth. So our ability to manage these patients would be limited to a short period of time, and we'll be looking at our regional partners for help to transfer these patients. What we're really looking at managing would be the milder ones, which hopefully will be managed in the community, and the moderate ones, which could manage in the ICU, not requiring ventilation, but requiring a supportive so either oxygen or provided with a mask called a CPAP machine. So it's those two things we should be able to deliver with our medical staff and nursing staff on site. But the more complex ventilation for COVID patients will more likely require transfer to a tertiary care facility, which would be, in our case would be Waikato.
Right. So I'm just trying to put like some I guess reality to the words like ventilators, etc., because when those of us who we're quite close to the medical system, and they're obviously you guys who are working inside of it, so you understand the complexity of operating a ventilator, right? But to the common layperson in the community, that they hear, oh, it's a piece of machinery, like you should just be able to learn how to turn it on. You do this, you do that. I know how to operate this thing. I can operate a car jack. I can operate, my battery charger. I can operate it. I can drive a tractor. These John Deere tractors are very technical these days. If I can operate that, surely I can also operate a ventilator. But that's not necessarily, that's not the case.
Not
right?
the case.
These are highly technical machinery. The other point that I also wanted to highlight that Jim made was that it's a one-to-one specialist care. It doesn't mean that it's, and again, this is not only just, this is not really speaking to us because we're the converted, right? It's more about putting that cordial out there. So if there are any lay people watching this, is that one-to-one care will require, at the minimum 2, probably 3 nurses to look after one person that's on the ventilator, because we can't expect one person to monitor that one ventilator for 24 hours. They have to work in shifts, right? So it was just, it was just more about giving voice to how difficult it will be for our system to do this, and more to make the point that the difficulty doesn't have to come if we get high levels of vaccination. So thank you very much for your report, Jim. Thank you for your contextualization and medicalizing of my layperson terms there, Anil. I appreciate that. Thank you.
Thank you, Josh.
So I think just on your John Deere tractor analogy there, I think the difference around this is that you've got a person connected to a piece of machinery that's carrying out a function for them that normally they would do for themselves. So you've got a completely artificial situation where you've got a machine carrying out a function for somebody that they're unable to do because their lungs are just so badly affected by the virus that they can't breathe anymore, and the machine has to do it. And I think we've all seen pictures and seen videos of people suffering from the effects of the virus, and the reason why they need to be connected to a machine. So to do that, they need to be sedated, so they're not struggling against the tube down into them and having to have the machine ventilating them, putting the air and the oxygen into their lungs, and then letting it out again and again and again and again. So in terms of the John Deere and the person driving the John Deere tractor, you've actually got a person over the top of that, looking at the whole dynamics of how the machine, the John Deere tractor, is operating, and how the person that is operating it and doing the work, how that's working together. And so you've got this person who's doing that. This is the nurse that's doing that, but then as well, you've got to have the doctor, as Anil was describing, to actually understand also their part in this, about how is it working? How's the lung function going? Are they reaching? Are they getting the right amount of oxygen to their brain? All of those sorts of things while they're on this machine. And then, when are the trigger points about how we're going to be able to get this person off again? Because that's the ultimate goal for their lungs, to be able to repair and to get back again. And of course, we haven't even talked about long COVID. The numbers of people in our community who will get the virus, who will recover, but will have long-term effects And I think those have been well publicised. You know, Ellen DeGeneres is a perfect example of that, if we wanted to name somebody who's experiencing that.
Andy.
Yeah, just with the timing, I'm getting really concerned about. You indicate that there could be a time that it is here and there'll be a real growth in demand. That time could exactly match time when we're losing staff, because of there is reluctance within this organisation still to be vaccinated. So if that time, what's going to happen there?
We've got a very small group of staff who are not vaccinated at this point. We are working with those people. The government's requirement for health workers to be vaccinated has been put back 2 weeks. So that wasn't necessarily about DHBs, it was about other providers and their ability to provide cover. So we're on the same time schedule as education now. So we've got a little bit longer to work with those staff to assist them around whatever's holding them up to be able to get vaccinated.
All right, yeah, I probably thought the number was a bit bigger than maybe.
The important point is it's a very small number of health professionals. Tony.
So how many ventilators do we have?
7.
Yeah, but we've got plans also that, you know, if we aren't, you know, I guess Anil was talking before around people being able to be referred out. That would be in the situation that there was capacity to refer out, so that Waikato actually had space to be able to take people from outside of their district, and that's a factor that we need to be aware of as well. So yes, the first preference would be to transfer people out that were at that level of care to a specialist unit where they are actually got intensivists and people like that to be able to manage the care. But we need to also plan around the fact that that may not be the case, that may not be possible. It will be very difficult to rescue large amounts of people who've got the virus. It's as simple as that.
What sort of capacity have the really big hospitals got, like Waikato?
Well, I don't know exactly, but we know that Auckland, with the capacity that they've got, is severely stretched and is asking the rest of the DHBs consistently to help with nurses, midwives, you name it, to be able to go there and assist. We've been very constrained in being able to do that because we are, you know, we don't have that much capacity here ourselves. So we've been reliant on our other larger DHB colleagues to be able to provide support for Auckland in relationship to that. Not that we haven't had staff here who volunteered to go. So it's.
What about ventilator numbers? Something like Waikato? What sort of?
I don't know.
Jim, did we increase our number of home oxygen machines that we can care for the less sick ones in the community that just need a bit of gas?
I'm not sure if we actually got extra. There's been a problem with CPAP machines in the community with recall of those and needing to do that. I don't know that we've added an additional oxygen concentrators is what you're probably talking about in the community.
Because there might be a need for that if we can keep them out.
So what we know very well is the experience of other countries and Auckland is that you can manage people in the community very well and reduce the chances of them requiring to be hospitalised and or ventilated. And so there is a whole piece of work that has been done to take the work that's been done in Auckland and in other countries to create a standardised pathway for people in this country for management within primary care. You attended the meeting last week.
I'm just thinking that if we do need more people in the community that require oxygen and all our machines that are in use for people already on it, how are we going to support them? Just to use some bottles. Got much bottles? Extra bottles?
I don't know the answer to those.
Yeah, because I think we could probably get a few extra machines just in case.
So we should those are a set of things to talk about in resurgence planning, which is well underway within the hospital, but something we're going to get briefed on a bit later today.
Only because I'm going to that meeting tonight before we get asked.
If you could just add, if it's all right, Kim, what they've done in both New South Wales and Victoria is that if a patient requires oxygen, they need to be in a hospital environment. The saturations drop quite dramatically from what is normal to about 70%. So it's quite a marked drop. And so if they do look like they're sick and require oxygen, they need to be in a hospital environment rather than in and you need to try to the oxygen to higher levels. So they haven't used the supply of oxygen into the communities. It might be slightly different for those with COPD and things like that sort, but in general, it's been managed in the hospital setting.
I'm just thinking if we get overwhelmed, we might just have to push them out.
Yeah, I think what Anil's saying is that it really isn't an option to try and manage people in the community that are that unwell with COVID-19, that their saturation levels have dropped to a point where they need oxygen. That you've got that you're on a
change of trajectory.
Yeah, you're not going to be able to manage it within the community successfully to retrieve that situation without hospitalisation.
And it's dire and becoming increasingly dire by the day as we see, COVID stretching out beyond the Auckland borders now.
Yes, it appears to be just gradually moving community by community. So I suppose that's unsurprising, given that communities between towns in the Waikato have people that interact, between one another. So it's just gradually moving closer. And then the occasional situation like we've had in the last few days where we've had people who have, for legitimate reasons have been outside of the Waikato-Auckland border and have then tested positive as in Blenheim or as in Hawke's Bay, Wairoa, with a contact of Wairoa, not tested positive, but a contact of a person in Wairoa. So it's that combination of gradually seeding in communities that join together occasionally, and then the jumping around the country, as has happened in Northland and in Blenheim.
Okay, any more questions of Jim? Meredith.
Kia ora, Jim. Thanks for the report. Oh, I just froze. A couple of things I want to thank you for. I see the discussion around suicide, respect to a number of, sorry, I just need to get to it so I can see what I was going to say. I just appreciate that there has been some considerations because we know in our region this is still quite a big issue, so just wanted to thank you for that. But the drinking water discussion, I wondered whether, just as councillors around the table, we've had that debate with respect to and how does the DHB or the PHUs who are now looking to give data to the new Crown entity, how's that going to play out? Because I know that council, you've seen and heard our debate respect to the water, just wanting to see how this will work best for our region. So just is there a difference of opinion, I suppose I'm asking, around DHB's concerns around the council's stand at this point, or are you seeing that the reason why, I guess, we're asking for a lot more clarity and there are more concerns, of course. So just that was my question with regards to that water paragraph in your report.
So it's just commenting on a national position, I guess, that includes the local council in terms of considerations. You're talking about the Three Waters proposal?
Yes.
So that's not what we are indicating, is that there still is pushback from councils, which includes ours, regarding that, and it may be well because councils are asking more questions regarding what the proposals mean for themselves.
So DHBs haven't been asked, in that framework of debate?
No.
Sandra.
Hi. Thank you, Jim, very much. I just had one question, moving back to page 21. It's actually part of the smoking key indicators, and a comment that you've made there around GP triage and the fact that it's gone very much, it's not even really telehealth, is it? It's telephone consultation. Looking past our current situation and what you're seeing offshore, Jim, is there a move back to normal when it comes to people, when I say normal, face-to-face visits with GPs? Is there a time, is it happening yet across Europe or the US where people's GPs are opening up again? I guess because I can see so much pressure coming on our team in the hospital environment because of the nature of triage outside of it currently.
I'm thinking that there'll be a number of factors that I don't think we'll ever get back to the same rate of people attending in person in primary care. I think that there's a number of reasons around that. I think that there'll be some hangover effects around the effect of the pandemic, and the pandemic is going to be with us all of 2022. That's nothing more sure about it than that, and so that will still have an effect all the way through 2022 and 2023 at the rate we're going. So I don't think that will have much difference. I think that primary care has learned a lot around remote servicing of people's needs within the community, and they will continue to utilise that. So it's been a catalyst around some of that. And similarly, I think that people in the community have learned a lot around remote access to their general practitioners and primary care services. So they will want and demand for more of that to occur online and through other means rather than personally appearing there. So I think all of those things will change the dynamics from now on because of that. So I can't see that there will ever be the return to the same rate, but definitely the numbers of people going through in person and in primary care will start to improve again, and again related to people being vaccinated and having the vaccine certificates and enabling them to take advantage of them.
Yeah, I'm sort of thinking outside of the COVID space. As I say, we're staring it in the eye right now. It's very hard to see out and beyond it currently. I guess I just worry a wee bit that some of those underlying health issues that prior to COVID, way back in the days before 2019 came to an end, when a GP had the opportunity to ask about healthy living practices, it's very, very hard to have that conversation, I think, in good faith, I guess. Unless you're actually in the room with your GP. For a lot of people, I'm not sort of talking everybody, and I certainly take your point that there's some real efficiencies to be gained from what we're learning now. I just worry that we're going to slip in some of those areas where a GP is able to question, those healthy choices that are good for all our people.
Sure. I think I was going to say too, I think if Os Mansell was here, he would tell you that all-cause mortality rates in countries where the pandemic has been more prolific than in this country have shown an increase which is not completely related to the impact of deaths from people from COVID-19. So when you've got a health system that is focused in on one particular threat, it's just impossible for people to be able to access the health system or for the health system to be responsive to everything else that's going on in people's lives. And so, I was just talking to Nicola before, and currently we've got our whole public health team 100% diverted towards work around tracing and swabbing and vaccinating people. So you're not getting the benefit in the health system around public health measures, not just treatment measures, but just plain basic public health measures. And so you can't keep on doing that for a long period of time and not have an impact on your population.
And I think while it's not easy at the moment for people to recognise that we have to think about what a different health system looks like, there are many people who can deal with a phone call. But what's been happening is that they've had appointments made, and it's helping to synthesise better for our general practices, I think, where their best efforts should be focused and who would be easily transferable into a primarily virtual response for many of the things that we have access to general practice for, which previously may have taken slots for those who really need to see a GP because the visual contact makes it much more important for them to do that. And I think we'll see a different way of delivering primary care services, which sees general practice at the very top end of the work that they can do, much of it in diagnosis, much of it in supporting a pathway of care that should be accelerated by seeing a general practitioner. And we'll see those teams around them doing a lot more of the health and wellbeing components of the care that you're speaking to, I think, Sandra.
Yeah, absolutely, Nicola. And I think we're I guess the case I would think of would be mum coming in for vaccinations for baby and GP saying, well, you know, whilst you're here, when was your last cervical smear done, et cetera, et cetera, et cetera. So it's all of that. It's the overall health picture of people, and you're absolutely right, Nicola. I think this is a place where we're going to end up with general wellbeing, and then your GP to the side, almost not to the side, but leading it maybe is probably the right way to say it. But I just wanted to flag it now because it's probably one of those things that coming, you know, people are very targeted right now, quite rightly. But I guess it's our job to look out into the future a wee bit more and just keep those things in mind.
Yes, I think you also need to remember that we need to be talking primary care here too, not just general practice. So I think the scenario too is also where the whānau health nurse and the vaccination assistant are in the home vaccinating the pepe, and also talking with mum around her cervical smear, and with nanny that's there around her flu vax. As you know, plus everything else that's going on there. And while that's already happening, it's what we're seeing, of course, and with the advent of things like vaccination assistance, is we're going to get a stepwise change in that too.
Okay, moving along. Jim, is there any? Oh, Josh, was there anything you wanted to feedback from Te Waiora or Nukatami Meha?
Oh, yes. I'd messaged Na and I did ask him if there was anything specifically that he wanted me to mention. Other than there are things that were in public excluded with the same things that were also in Hiwi Te Rangi, so I can talk about those when my in-committee stuff comes around. But he just wanted to just let us know that they are still looking to keep engaged with iwi reader reforms. So the Te Waiora Nukutai Memeha have been playing a key role in having conversations with the transition unit around iwi and the running of IMRBs, or whatever the acronym is. So many acronyms. But yeah, Te Waiora Nukutai Memeha met with the iwi leadership a couple of weeks ago to hear, because really the position for Te Waiora Nukutai Memeha is whatever the iwi whānau wants to do in regards to the transition and stuff. So still keeping engaged in there, Madam Chair.
Ka pai. Thank you, Josh.
You're welcome.
The financial report, so I know that got quite well interrogated at Frank, and just in the first instance asking Jim and Heather if there's any further comments you want to make on the financial report.
No questions.
Heather, Jim?
I just draw the attention to that little summary at the bottom of page 34 that Craig's put in there around our situation year to date, and the confidence, the confidence we have around that. And I think, did you say that Craig will be here a little bit later, so he'll be able to catch up with any questions later on.
Does anyone else have any comment on the financial report? Okay, we can bring that back up again if you want to a little bit later on when Craig's available. So at this stage, we'll just note and receive that. We're then moving on to subcommittee reports. So there's none in the public part of this meeting. The vaccination update, I think we'll just take as read because we're going to be we've talked quite a bit about it, and there's some more matters on vaccination that we'll talk about in the next session. So at this point, I will resolve to exclude the public from the balance of our meeting. And before we go off, thank you very much for joining us today. We hope it's been an informative session for you, and we'll look forward to seeing you again in November. Kia ora.